Hey, welcome back. Let's go through the tracts and fasciculi. So, tracts would be like dermatomes, and those would be myotomes, and these are all, of course, they all correspond to a certain spinal cord segment. In a disorder, in a complete segment or resegment of the spinal cord, all sensation and ability to move are completely lost below the injury. Incomplete depends. We're going to go through that. The causes would be all of these. Okay, so let's go through it. Complete, once again, complete paralysis, complete sensation loss. Quadriplegic is going to be due to the upper cervical segment transection. Paraplegic, the transection is in the thoracic region, and these will result in spastic paralysis. Voluntary control over the bladder and the bowel functions will be lost. The Brown-Sequard syndrome is going to be the hemisection of the spinal cord, and that's going to affect the spinothalamic, corticospinal, dorsospinal tracts, all affected. And at the level of injury, there's going to be ipsilateral motor neuron loss. However, there's going to be a bilateral loss of pain and temperature, and an ipsilateral loss of fine touch and proprioception. Because remember, that's the tracts affected. It's going to result in flaccid paralysis. There are no signals going through, so there's no contracture. Below the level of injury, the ipsilateral upper motor neuron is affected, and there's going to be ipsilateral loss of fine touch, vibration, proprioception, and contralateral loss of pain and temperature sensation. And this is going to be this is going to result in spastic paralysis. So there's going to be like contracture occurring. So what to know here? Above level of injury, lower motor neurons going to be affected. Above the level of injury, ipsilateral motor neuron affected. Okay, so what happens in the upper motor neuron paralysis? Usually above the pyramidal decussation, there's going to be contralateral paralysis. So it's above the cross, right? So it hasn't gone through. Below is going to be ipsilateral paralysis. And the Babinski reflex is going to be positive. So when you run something kind of like hard and sharp, kind of like they're using something that looks very strange, but like the bottom of your reflex hammer across the foot, in a normal person, your toes will curl, but in a positive Babinski, the toes will flare out. This is actually normal in children, but that's because their nerves have not formed a complete tract yet. But in this, you know that an upper motor neuron has been damaged. So the connection to the lower motor neuron is lost. That's why the toes flare. It's only going to rely on very primordial like reflexes. But the lower mirror neurons are going to be hyperactive. The control is lost, and it's going to result in the spastic paralysis and rigidity and exaggerated reflex. If you tap them gently, let's say on the patella to test the patellar reflex, they're going to like kick up very, very high. There's not going to be like a twitch. So in upper motor neuron paralysis, there's not going to be any loss of muscle tone. There's no wasting. In fact, it could be like hypertrophy because of the spastic paralysis. So here is the upper motor neuron lesion. It's going to really only affect like the lower fourth of the face, depending on the side of the injury, right? So in the lower motor neuron paralysis, there is going to be decussation. So both like the entire half of the face will be affected. There we go. Sorry. And it's due to the anterior horn cells, cranial nerve nuclei, and motor fibers of the peripheral nerves is lost. So this is going to be resulting in atrophy and flaccid paralysis. So the syringomyelia is a dilation of the spinal cord, and it presses on the lateral spinothalamic tract, and of course that's going to result in a bilateral loss of pain and temperature. Tabus dorsalis is very specific. It's going to be due to an infection by syphilis, and the syphilis bacteria is going to eat through the posterior column of the spinal cord. And there's going to be a loss of the proprioception and tactile discrimination below the lesion. And when the patient closes their eyes, they're going to fall down. And there's a test called Randall's test. So patient will have to close their eyes and put their feet together. In a very positive test, patient will just fall down the minute the eyes are closed. Otherwise else, you push on them gently. And for a normal person, our sense of proprioception is going to be intact, and we can like brace and kind of like lean forward to compensate for the movement. But in somebody with the ataxic disorder, they are going to like fall right on over. Of course, there's going to be the finger to nose test, test for proprioception, test for the tendon reflexes. They're going to be lost. The underwear that the bladder is full because they cannot feel that parasympathetic innervation anymore. So here's the morphology: dorsal column degeneration, orthopedic pain, reflexes are decreased, shooting pain, Argyll-Robertson pupils. We'll go through that later, but there's going to be a problem in pupil constriction, locomotor ataxia, impaired proprioception, and the cause, syphilis. Okay, so Friedreichs ataxia is going to be somewhat similar to the syphilis presentation, but it's going to be inherited. And it's going to be a bilateral degeneration of the Clark's columns and the posterior spinal cerebellar tract. Unfortunately, this will result in ataxia and dementia. Caldoquinas syndrome, again, is going to be usually due to like a fall, like on the tailbone, and it's going to compress the caldoquina, and it disrupts the motor and sensory functions through the lower extremity and the bladder. It's most common in the lumbar section because it's the most mobile of the vertebral column. There's going to be severe pain, unfortunately, along with flaccid paraplegia, and there's going to be retention of urine, disturbances in rectal reflexes, and in males, the person will not be able to maintain an erection. So how can you treat it? You can do IV steroids and surgery in some cases. Polio. It's a viral infection and it involves the anterior nerve cells. There's going to be lower motor neuron paralysis, so that's going to result in flaccid paralysis. Tendon reflexes are going to be gone, of course, because the anterior horns are going to be affected. They're not going to communicate. Muscles are going to atrophy. That's due to the flaccid paralysis. And if it involves S2, 3, and 4, there's going to be bladder and rectum problems. And if it involves T1 to 2, there's going to be Horner syndrome. So spondylolysis is a herniated disc. ALS is when the lateral horn cells are going to be replaced by fibrous astrocytes, and it's degenerative. It involves the motor system, both like upper and lower. So once again, it's flaccid paralysis if it's going to affect the upper motor neurons, and spastic paralysis if there's going to be the lower motor neuron lesion. Anterior cord syndrome, usually due to trauma, and it's going to result in a loss of pain and temperature. However, the positional and vibratory sense is going to be intact since the gracilis cuneatus and they're going to be intact. Usually caused by a flexion injury, and this generally has a very poor prognosis. Central cord syndrome, this is where it's affected. It's mostly in the cervical region, and there's going to be a loss of motor and sensory functions in the upper extremities, and it's caused by a forced hyperextension, and it's kind of rare. Posterior cord syndrome is due to a variety of things, and usually the lesions are bilateral, and there's going to be a loss of conscious proprioceptive sensation, discriminative touch, and vibration down to the below the lesion. Once again, it can be due to demyelinating disorders, compression, blockage in the arteries, results in ataxia, falling sensation. It also has a pretty poor prognosis. Renshaw cells, just to kind of go off on a little bit of a tangent, they're going to be your inhibitory interneurons. They're located in your anterior horn, and it secretes an inhibitory transmitter that produces IPSPS that acts on the motor neuron somas, and the neurotransmitter is usually glycine. That's it for now. Thank you for your attention, and good luck studying.